hypoechoic, and a lot of times they have this cystic degeneration inside. Some of them larger amounts of cystic degeneration, and some of them smaller areas of cystic degeneration. This is a typical appearance of a nodule. Yeah? If you look here, this is again a hypoplastic nodule. These are transverse and longitudinal scans, and some of them look very solid. They don't have any cystic area. And sometimes if they are single nodules, I'm sure you know that these single nodules you probably need to do an FNAC because you want to know what they are. And if you look here, you can see that there's a halo sign. But there's you know, we have moved away from this this belief that if you see a halo sign, it's most likely benign. I mean, it guides you towards thinking or towards a line of writing down a normal report. But having said that, we have also seen malignant lesions with a halo. So this is the halo that you see around it. This nice hypoechoic line that you see around the nodule. All right. Okay. So this is your typical colloid nodule. And what the colloid does is, when it's inside the in here in ultrasound, it gives this appearance of a comet tail. So if you look at this, you know how the comet is, and it has a tail at the back, right? So it basically has that appearance. And if you see that, you're 100% sure this is colloid. You don't have to worry too much, okay? So that's what the colloid looks like. It's very echogenic, a bright spot like this. And this is definitely a colloid nodule, so we don't need to move much further from that. Right, comet tail artifact. The clinical importance is you definitely wouldn't find this in an abscess, yeah, because air pockets don't look like that. And it's not seen in any malignant nodule, and of course it will help you also to select your needle. If you see a colloid, you can't put in a very thin needle in case you want to aspirate. You know that you have to use a larger needle because it's very thick, very viscous. So if you put the normal green needle, it won't come out. You have to use the orange needle, which is really thick. Okay, so if you look at this, this is a nodule. And of course you can see that there's some area of cystic area here, very irregular. This is a classical nodule where a patient comes and tells you, or a patient who's had multinodular goiter before suddenly tells you this nodule has suddenly increased in size. Most likely, most of the time, that nodule has undergone hemorrhagic transformation, or rather there's a hemorrhage that has occurred within the nodule, and therefore you will see this sort of image. Okay, what you see is a nodule with an irregular border. Can you see that? Yeah, there's a very irregular border to this nodule, and similar here. And what you see is internal echoes like this inside here. Okay, now if you look at cysts anywhere in the body, whether it's in the thyroid, whether it's in the breast, whether it's in the ovary, you classify your cysts as simple cyst and complex cyst. Okay, so a simple cyst is a cyst that you can draw the line or the outline with a pencil. It is very thin, very nice, nothing inside, completely black or anechoic, which means that it completely looks black without any echoes inside. The moment that the wall of the cyst becomes slightly thicker, or you see this sort of thing where you have internal echoes, it's called, like dots inside, this cyst no longer is simple and it becomes a complex cyst. It doesn't mean that it's malignant, but it just means that it's no longer a simple cyst. It's a complex cyst and it will need further investigation or follow-up. Yeah? Right. Okay, so this is a nice picture. Actually, if you show this picture to the gynecologist, they'll tell you this is endometriosis because it looks exactly the same. Okay, so this is what hemorrhagic cyst with debris looks like. So it is all the debris has settled down here, and you actually have a fluid level or fluid debris level, and and that's exactly what an endometriotic cyst looks like in the pelvis as well. Right. Okay. So what happens to the multinodular goiter, and how is the calcification that appears in a multinodular goiter? The multinodular goiter calcification is amorphous, very thick calcification, or a annular calcification, which means that surrounding the nodule itself. So this sort of calcification, now I know it's a little bit difficult for you, you see nothing at the back here, and I will give you an explanation for this. Now this is the nodule, okay, but you really can't see the nodule very well. All you can see is these areas of calcification, and then a black shadow at the back. Now this is because the ultrasound beam, when it enters your body, when it comes across calcification or anything which is hard, the ultrasound beam that travels in this direction cannot penetrate that. So all the beam is pushed back to the front, and so behind that you get no information. On the other hand, if you see here, you can see an image right through. That's because the ultrasound beam has traveled further, but here it can't. So wherever in the body, whether it's gallstones, whether it's kidney stones, whether it's calcification, the thyroid, wherever it may be, you will get this similar picture. This is calcification, and that is the posterior acoustic shadowing that you get, which simply means that there is no ultrasound information behind here. It doesn't mean that there's nothing there. Yeah, the nodule is definitely there, but you just can't see it. Okay, and this is annular calcification, which is also the end stage of a multinodular goiter nodule. So, coarse calcification, like you see here, or annular calcification, like you see here. This is actually the end stage of it. Yeah. Right. So now we go on to a Doppler, and predominantly in multinodular goiter, you will see perinodal vascularity, which means there is vascularity around the nodule, but not so much inside. And I will show you the difference. I mean, we try, if we see a lot of intranodular vascularity, that's one of the cases, one of the reasons why we would do an FNAC as well, because we would be a little bit worried. Yeah. Right, thyroid cysts. We hardly ever get any true epithelial thyroid cysts. So most of the time when we see thyroid nodules, they are thyroid cysts, or rather cystic nodules. They are most likely cystic degeneration of a nodule that has already been there. But the thing that we need to keep in mind is that 20 to 30% of papillary CA has a cystic component on ultrasound. Yeah. So let's look at this. This is if you can see here, this is a simple cyst. Very thin walled, nothing at all, no debris, completely black, and that's exactly what it looks like, yeah, as compared to a complex cyst. All right. Yeah. So if you look here, like how I showed you earlier, you've got internal echoes, you may have septations, and behind every cyst or every structure in the body that has fluid, you will have an echogenic area like this, which is posterior acoustic enhancement, which confirms for you that what you're looking at has fluid inside. Do you remember just now the calcification? It has a black shadow, right? So that is calcification, posterior acoustic shadowing. This is a cyst, posterior acoustic enhancement. So if you're not sure, because you look at this sort of thing and you think, is it solid, is it cystic? You look at this enhancement, you will never get it behind a solid structure, so you're definitely sure this is cystic. And the reason why you have all these internal echoes is probably because of hemorrhage. Yeah? Right. So now we'll move on from multinodular goiter to papillary CA. Now, as we know, nothing is really fixed, so it can look like anything. But there are a couple of features that will direct you towards papillary CA on ultrasound. It can be solid, a cystic component in about 30 to 40%. It can be very homogeneous, it can be hypoechoic, but the one thing that it has is punctate calcification. And when we see this punctate calcification, as opposed to the amorphous thick calcification and the annular calcification of the multinodular goiter nodule, you have to be vigilant. Yeah, lymph nodes, of course, and if you notice, you have a halo here in papillary CA. Right. So the other thing that's important, and I will deal with this later as well, but what I wanted to show you is that it's very important if the patient has nodes for you to characterize the nodes as well. And the one thing that's very important about papillary carcinoma nodes is that these are the only nodes that are hyper-echoic relative to muscle most of the time, in majority, as opposed to all the other CAs. And a lot of, in a high number of them, they will also have the punctate calcification in the lymph nodes. Not always, but quite a few of them. All right? Right, so let's look at this. And this is punctate calcification. There are small areas of calcification within a nodule. And when you see this, you have to be very vigilant that this could be a malignancy. Can you see that? Yeah? So this is a hypoechoic nodule, right? With multiple solid, it's solid, multiple punctate calcification within. Yeah? This is another one, but very diffuse, ill-defined, can't really tell what's going on there. That's the jugular vein and the common carotid artery, and there's definitely something going on here. The moment we put on color, can you see the color? It's completely different from the nodules we saw just now. It is a lot of color. It's really literally taking up the entire nodule, and that tells you that this is a very chaotic vascular pattern. So this tells you that you're definitely dealing with something that is suspicious. Okay? Right, anaplastic. Just to go through this, of course this is a diagnosis which is clinical, but just to show you, it's ill-defined, hypoechoic, often cystic. They have a cystic component as well. And the thing that is different about this is that it has the amorphous calcification that is similar to a multinodular goiter calcification. Life is never easy, guys. Right? So areas of necrosis are seen because this is quite, it necroses quite easily. Background nodularity, which means that the lobe itself, and a very chaotic vascular pattern on color flow imaging. All right. So let's have a look at this. You have frequent associated lymphadenopathy with this anaplastic carcinoma. Let's have a look at this. You can't even see the border of the nodule, right? It's very ill-defined, very hypoechoic, full of there's cystic structures around here. If you want to biopsy or do an FNAC, you have to make sure you try and target the solid areas, because this is necrosis. This is what necrosis looks like. It's a little bit like the hemorrhagic transformation of a nodule, but the difference there is that you can actually make out the nodule. Sometimes here you can't make out. It's so ill-defined that you can't really tell where's the border of the nodule and where is the normal thyroid gland. Okay, so it's really, really ill-defined. That's another picture of anaplastic carcinoma, huge nodule. Yeah, patient presented with increase in size, and that's it. Right. Okay, medullary, taking you through all this. Ultrasound features are similar to papillary carcinoma, solid, hypoechoic. Most of these masses are hypoechoic. Yeah, that means that they are darker, or rather, darker or blacker than the surrounding thyroid gland. All right. Echogenic foci, you can have calcification similar to what you see in papillary CA, and it's usually denser, but that's a little bit difficult to tell. The thing is, if you have a patient that comes to you and says, I've done an ultrasound and this is the report, and the report says that there's punctate calcification, you need to think that there's something going on. And of course, all the malignancies will have a very chaotic vascular pattern. Okay? This calcification that I was talking about, that you see even in papillary CA, the calcification is also seen in the nodes in medullary carcinoma, but the difference is that these nodes are dark. They are hypoechoic nodes. The papillary carcinoma nodes are the only ones that are brighter than the surrounding muscle. Okay? Right, so let's look at this. Again, very irregular, and you have this punctate calcification. If you notice, do you remember the coarse calcification I showed you earlier has got a shadow behind, right? Okay, punctate calcification usually does not give a shadow. But in this medullary carcinoma, you actually have denser calcification, and they can actually give you small areas of shadow like this, right? Which you don't really see in punctate calcification, which is in papillary CA, but in medullary carcinoma, you can get that. Right, follicular lesions. Now, follicular lesions, you know that you're unable to actually tell by FNAC. I'm sure Man will take us through all that, and you need the entire histological specimen. So when we look at a lesion, and it is, I will show you some of the images, we try to see, to define them and identify them as follicular, but we say follicular lesions. Yeah. So these are the features, and most of the time they are hyperechoic. So all the nodules that we've seen so far, multinodular goiter nodules, papillary carcinoma nodules, anaplastic, medullary, all are dark nodules. The only thing that is bright, just to bring you back, is the papillary carcinoma lymph nodes, right? Okay? But when you deal with an echogenic nodule, that pushes you towards a follicular lesion. Okay, that's one of the few lesions that appear echogenic on ultrasound. So this is what you see in a follicular lesion. All right. Right. So I think that this is what I've said earlier, that you cannot be made, the follicular carcinoma cannot be made on ultrasound unless you have, you know that there's vascular invasion and you've already got a pathology report that tells you all that. Okay. Right. So this is a typical follicular lesion. We don't know whether it's benign, we don't know whether it's malignant, but this is what a follicular lesion looks like. It is echogenic and bright as compared to all the other lesions you saw just now. Very nice and well defined. It can be irregular, but whatever it is, it will be echogenic. And there you see, that is it. This one has got a bit of echogenicity, but has got a bit of necrosis as well, and therefore it's a bit darker. So this is actually a follicular carcinoma. It probably started out being an echogenic nodule and then underwent necrosis, and when it undergoes necrosis, it has an hypo area, right? So that's a follicular lesion. This is a benign one, and that's a malignant one. Right, thyroid mets. I think they all appear very similar to what we have seen before, and I think most of us in this room will know that unless you stick in a needle and send it to Dr. Mann, you won't be able to tell. So, large and solid focal mass, or it can be a homogeneous mass as well. It can involve the entire thyroid gland. It's usually well defined, but it can be irregular. It can be heterogeneous, homogeneous. It doesn't really have a specific vascular pattern, right? And usually you will have, a patient would have undergone a CT scan or will need a CT scan if you suspect that the thyroid is not the primary CA, right? Okay, so overall incidence of thyroid mets actually is, with the known primary, is anywhere between 2 to 17%, and the commonest signs are these: melanoma, breast, and RCC. So let's look at them. Very well defined, nice, solid, hypoechoic nodule like this. One look at it, you can say, looks like MNG. But, you know, sometimes when you have these solid nodules, and especially if, you know, these nodules don't, thyroid mets don't usually take up that much vascularity, it's always worth putting a needle inside. Yeah? Lymphoma, the nodules are similar, very dark, hypoechoic nodules. They can be diffuse as well. Or it can be just a total diffuse enlargement of the thyroid gland, right? So it can present in any way. It's very clinical, right? So that's an enlarged thyroid gland, heterogeneous hypoechoic echo pattern that you see in lymphoma. Okay, we'll move on to thyroiditis. Do you want to ask any questions before I move on? Anyone? Okay, so we'll go on to thyroiditis now. So the most common is Hashimoto's, so we will carry on to that. I think I'm going to skip all this because I'm sure it will be dealt with the others. So I will move straight on to the sonographic characteristics. Okay. So what you have is you have a diffusely, this is the acute phase, right? You have a diffusely enlarged gland, and you have decreased echogenicity, which means that, you know, your normal thyroid gland is bright. Now the thyroid gland looks darker, and you can actually compare that to the surrounding muscle. So for those of us who do ultrasound on a regular basis, we can tell that this thyroid gland, of course, does not look normal. Having said that, of course, this is together with all the information that the clinicians give you. Yeah. Multiple ill-defined hypoechoic areas. So when it's hypoechoic, there's small dark spots, and I'll show you a picture soon. Echogenic fibrous septa. These are all the things that you see on ultrasound. Hypervascular on color flow imaging, and this is an acute phase. All right, so let's look at this. So what you see is a Swiss cheese appearance. That's what I call it, right? So you have this really irregular, I mean, it's nice and round, yes, the whole nodule is involved, the whole lobe is involved, and what you see is that you see these small dark spots all over the place, and this thyroid lobe is actually darker than normal. Right? So small, and this gives you the Swiss cheese appearance. And what happens is you actually see these fibrotic streaks, which are fibrous septa, which are echogenic, these bright white lines. When you see a lobe that looks like this, it is dark, it has got very, very heterogeneous sort of picture, it's not smooth, it's got all these fibrous septa. You've got to think of thyroiditis. So look at the color flow. In a normal thyroid gland, you're not going to get that much flow. This is a lot of flow within the thyroid gland itself. It's just all over the place. It's very, very mosaic pattern. So now what happens to the gland when it's in the chronic phase, right? No more vascularity. The vessels go away because it's not acute anymore, right? And it becomes small, the thyroid lobe, and atrophic and very heterogeneous looking like this. Okay? But the thing that tells you that it's not in its acute phase anymore is it doesn't have the florid vascularity that you would get if it's acute thyroiditis. Right, abscesses, just like abscesses anywhere on ultrasound, you will see a hypoechoic mass and you'll see these dots. This is not punctate calcification, but this is air. Right? Spots of air which you see inside an abscess, and you can, if you hold your probe on the thyroid, you can actually see the movement of the pus, and there will be no movement otherwise. But here you would see, and of course clinically, if the clinicians think that this is an abscess, it confirms the diagnosis, right? So I was just looking at this, and I think it will be interesting. I'll pass it to Alex, and maybe he can get this over to you all to read and have a look. This is taken off a paper, which was a consensus that was done to look at the different things that you see on ultrasound and its sensitivity, specificity, and positive and negative predictive values as far as all these things are concerned. Yeah. Same thing here, the recommendation as to what you would FNA and what you wouldn't. And most of the time, if you have microcalcification, you are going to consider an FNA. I would consider an FNA even if it's smaller than 1 cm. I would think that nowadays you can catch nodules even much smaller than that. Yeah. So I would say if you have microcalcification, you need to FNA your nodule. So this is something I won't read off here, but I think I'll just pass to Alex. Okay. Now we go on to the neck nodes. And I always stress this, and I stress it over and over again, a thyroid ultrasound is not complete unless you do the neck nodes. You have to do the entire neck, look for nodes, whether they are there or they are not. It is so important to complete your report with the presence or absence of neck nodes, right? So just to take you through this as to how we would classify them, usually I would start with the submental nodes. That's 1, 2, 3, 4. And that's submental over here. Then you have the internal jugular chain upper, mid, and lower. And then you go to the back and you come to the anterior cervical. Usually, even if I tell them to just look at the cervical region from the front to the back, we'll call it anterior and posterior cervical. It's sufficient enough. But if we find nodes, we like to classify them. Yeah. Right. Okay. Ultrasound is the best modality, again, for nodes in the neck, in the axilla, you know, when you have breast cancer and things like that. So, because it's very, very good at giving you the fine internal architecture of the node. Nothing else can give you this, not CT, not MRI, but ultrasound can do that. So it will show you the size, it will show you the size, the shape, the border, the echogenicity, which is very important, the internal architecture, and again also whether it's vascular or not, which makes a difference. Okay, so benign nodes are usually elliptical, which means it's oval, like an almond shape. The moment the node loses that shape and looks round or looks otherwise, then you know that something is going on. It's either a reactive node or it's a malignant transformation, or it's a metastatic node. Okay? Right. So let's look at this. This is what a node looks like. This round thing, and it has a fatty hilum. Okay? So the first thing that happens during an invasion of a node is the loss of the fatty hilum. Once the fatty hilum disappears, you know that something is going on, right? And they're really tiny. I know it looks very large here, guys, but this is probably like, what, some 5 mm or 4 mm or something. They're really small, yeah? Okay, so let's look at this, right? You have a hyperechoic hilum, and that's your lymph node. That's how it looks like. Most of the time, although we measure the long axis diameter, when you are following up a patient or when patients are followed up, the short axis diameter is what is really important. Now, you're looking at this node, right? So that's a normal node. And the moment that becomes not normal anymore, it looks like this. It becomes hypoechoic, and it becomes infiltrated, and it becomes round. It is no longer almond shaped. Alright, so that's a malignant lymph node. Right, here you go, round hyperechoic lymph nodes from metastatic papillary thyroid CA. Now, I said that the lymph nodes are supposed to look echogenic, but sometimes they do look hypoechoic as well. Yeah. Echogenicity, right? They are usually hypoechoic compared to the adjacent soft tissue, except for papillary CA lymph nodes. And if you look here, you can see that this is a heterogeneous echogenic lymph node from metastatic papillary CA. This is another lymph node from papillary CA undergoing cystic change, right? So it can look like a nodule. It can look like the nodule that you have. And the calcification, although it's rare, you do find them in papillary CA. And you can see that, you can see the punctate calcification that you are supposed to see in the nodule in papillary CA. You can actually see it also in the lymph node. Look here. These are punctate calcification, right? Okay? So the borders, ill-defined nodes, usually they're reactive. Well-defined nodes, they're usually malignant. I'd go figure, but these things are just, if you have like an infection, you have a thyroid abscess or any abscess in the neck, they usually say that those nodes will not be nice and round. The nice and round ones will turn out to be the malignant ones. Yeah? But these are all just guidelines for us at the end of the day, for us to have a look and see. Color flow imaging. So similar to what you find in the node or the nodule, you will find in the node as well. And most of the time, if they are benign, you have central, hilar or radiating vascularity, and if they are malignant, you'll have peripheral vascularity. Whatever it is, if I find a nodule I'm not very happy, or a node I'm not very happy with increased vascularity, then I will be vigilant about this node. And if you look here, there's just too much vessels around this node. Too much. Inside, outside, wherever, it's just too much. So this is a papillary CA nodule. Yeah? Look at this one. I mean, definitely I would look at this and say, yeah, we need to do something. Right? So these are metastatic nodes as well. And if you look at this, this is really interesting actually. You have a node, which is a large cystic metastatic node, undergone cystic degeneration, one solid area there, and when you switch on the color, you look at the amount of florid vascularity that that solid area has. So this already tells you that this is definitely suspicious. Right? Question and answer. So, A is benign or malignant, can you tell? Looks nice? Looks nice? Yeah, okay, looks nice. What do you think B is? Looks benign? Not sure, right? Okay. What is C? Classical, this one I showed you all just now. Hemorrhagic transformation maybe, yeah? Irregular cystic area. This is like a nodule which has cystic spaces inside. Maybe a cyst. Okay. Bottom line is that this is papillary CA. So we cannot tell. So in other words, we need to put a needle inside. Right? Yeah, because it looks very well defined, looks very nice, looks with a halo around it. You know, although we get a halo in papillary CA, but we also get halos in benign nodules. At the end of the day, we can't tell, right? Okay, so we don't need to perform an FNA in this because this is a very, very well-defined cyst, and we know that that is a cyst. Right. What about this? What is that arrow pointing to? Punctate calcification. What about this one? Yeah, okay, very good. So that's punctate calcification. So you all didn't sleep lah. You listened to what I was saying. So that's punctate calcification and that's colloid. And so you don't need to stick a needle in this because this is the ultimate comet tail that you see in colloid. Definitely 100% colloid, but that is punctate calcification and that's papillary CA. So malignant or benign? Why? Increased vascularity. Okay, fine. So this was a papillary carcinoma, yeah? What about this? Stick a needle in, yes. Okay, right. This is predominantly cystic nodule, small solid component up there, right? And this turned out to be benign though, yeah? But that's basically it, isn't it? At the end of the day, we see something, we need to stick a needle inside. Abnormal cervical lymph nodes, Again, okay, I won't put you on too much of this lah. Alright, central punctate acrogenicity, and this is actually metastatic papillary CA. And you can see the punctate calcification, small here. Some of them actually have dense shadows behind. Alright.